Sorry. Okay. So this is Dr. Underwood. He works at Magnolia Specialty Clinic, and he also is.
I do gastroenterology and liver disease, and I am also a patient.
Okay. So my first question is, how long is treatment? Oh, actually, so we're talking about ulcerative colitis. What do I want to do with the first question? Well, is ulcerative colitis common?
A good question. So no, ulcerative colitis, which is an inflammatory bowel disorder, is not too common. But we were seeing a higher prevalence these recent years, more so than ever before, and for a lot of different reasons. But yeah, we're starting to see it more and more. It used to be more of a European cultural predominance, but now we're seeing it in every single culture, including Hispanic populations, African Americans. So we're seeing it kind of expand, and I think that has a lot to do with particular diets, new diagnostic tests, people realizing what the disease is. So yeah, the prevalence has gone up.
Okay, second question. How long, well, it goes with another question. How long can a person live with this condition?
Sure. So, inflammatory bowel disease, once diagnosed, either through screening colonoscopy, labs, imaging studies, stool studies, once diagnosed, this disease is a lifelong chronic disease. So, the patient will have it for the rest of their life. Inflammatory bowel disease has two different diseases within that branch of inflammation. One is Crohn's disease, and the other is ulcerative colitis. Ulcerative colitis does occur primarily in the large intestines, and it starts rectally and moves up and through the large intestine as the disease progresses. Most of the time, it stays in the lower colon, lower part, and kind of comes across and spreads. There is a cure for it, which is surgical. But we tend to hold on to doing surgical means to the very end of treatment.
And how long is treatment?
Sure. So typical treatment is lifelong, and so if you have this disease, it's a lifelong illness, and we put patients on our starter medication. Typically, is what's called mesalamine or ASAs, and these medications have been shown to decrease the progression of the disease. They're oral pills and rectal suspensions and enemas, and that helps to kind of cool the inflammation down. That's one type of the medications. The other medications are directed at either modulating the immune system's response or decreasing inflammation, and that's typically through medications like the immunomodulators would be mercaptopurine, azathioprine, and the anti-inflammatory medications are typically, the biggest one is steroids like prednisone, and then our newer agents which block the inflammatory process at the point of it starting. And these are like our tumor necrosis factor medications like infliximab, Humira, those types of medications. And folks will tend to be on these for life.
And risks and benefits of treatment?
Sure, yeah. With any medication that we give, there's always going to be an upside and a downside to it. And each one has their own, effects. The steroids, which is one of the most powerful anti-inflammatories we have, when patients are really acutely ill with ulcerative colitis, what we call having a flare-up, we tend to put them on high-dose prednisone, which is a steroid. And prednisone will knock out the inflammation. It's like turning on the fire hose and putting out the fire. But the side effects of those steroids, especially in the long term, can be quite severe, including things like moon faces, where your face gets swollen. It can affect your sugar levels, so some folks can develop things like diabetes. It can also affect you mentally, causing depression, psychosis, and energy levels tend to be very high. So some of these folks have difficulty sleeping, they're jittery all the time. And then skin side effects like acne is one. And so there's a lot of downside to that particular medication, and that's just one of them. Some of the immunomodulators put folks at risk for infections or reinfections from things like tuberculosis or hepatitis, and even put you at risk for some lymphomas and cancers. So there's a lot of pre-testing that's done before we put any patient on those medications, and then a lot of monitoring for the rest of their lives while on these medications. The newer agents are more specific targeters of the inflammatory process and thus have a little bit less side effects. And these are agents that we actually call steroid sparing. The steroids are very powerful and very good to use when we have a flare-up, but we try to avoid them in the long term. And so some of these newer medications really help us avoid the use of steroids, and typically are injections or infusions that you get once every 4 weeks or every 8 weeks, which isn't too bad for patients to come in and get that done, and it tends to control their disease process quite well.
Oh, interesting. Another question I have you ever had a severe case of ulcerative colitis, like with the patient? And if so, how bad, and what was the treatment or options?
Yeah, absolutely. So, on a daily basis, we will get patients with severe flare-ups, and typically communication is key with everything. When someone is having a flare-up, what is happening with ulcerative colitis is the body's basically attacking itself, right? And it's causing an inflammatory reaction within the intestines. So the symptoms tend to be a lot of diarrhea, bloody stools, cramping, abdominal pain, and they're going to the bathroom, 10, 20 times in a day. Which obviously shuts down their life. They're pretty sick, pretty ill. At that point, oftentimes we may need to hospitalize them, to give them IV fluids, to put them on high-dose steroids, and to make them what we call NPO, or nothing by mouth, essentially resting the gut while we give it as much medications as possible. At the highest level of inflammation, sometimes because the ulcerations are within the colon, they can sometimes rupture, or you can get a bowel perforation, or something even worse, which is called toxic megacolon, where it's so inflamed the colon is enlarged, and that's puts them at extreme risk. And at these very rare times, but it does happen, we'll have to perform emergency surgery and potentially have a segment or the entire colon removed.
Okay, so with surgery, they have their colon removed, but does that require a bag? What is it called?
Yeah, colostomy bag.
Colostomy
Yes.
bag.
So it depends on the severity of the disease. So as mentioned before, some folks we will have on medications their entire life, and the inflammation, despite those medications, continues to progress and kind of takes over the entire colon. At that point, if we've used all the medications we have, the option, and they still are very, very sick, the option is to remove the colon. The most common procedure that we do now is a 2-part procedure where we remove the colon, and the patient will have a colostomy bag. And this first part of the procedure, where the large intestine is removed, the stool then is able to come out through the colostomy bag, and we allow the intestines to kind of rest and kind of heal themselves. And sometimes that's 6 months up to a year. Then we have what's called a takedown procedure. So these patients can then potentially not have to have the bag. It depends on if their small intestines are going to be healthy enough for a second operation. And so the second operation, or takedown procedure, there's several different approaches, but one of the more common ones is we will take the idea of a large intestine is that it's a collecting system for stool to come, sit, collect. And without that, our stool will just kind of run right through us. So we'll take instead small bowel loops, which we have many. As long as they're healthy and performing well, we can take those bowel loops and combine them, putting them together. One particular type of procedure is called a J pouch, where if you can visualize a J or a curve where we're connecting two small bowels together, and that allows a little bit of collecting system, and then we reattach that to the rectum so that folks can go to the bathroom normally. That is the end stage of ulcerative colitis, and at that point, without the colon, there's no need for the patient to be on any medications. We still do colon cancer screenings, depending on if we've spared the rectum, then we would need to continue to monitor for things like colon cancer, even though the colon's removed, a part of the rectum is still there. So there are other types of procedures like that, but that's the primary one that we tend to use at the end of the disease process.
Oh, wow. Very interesting. I think that's all the questions for now.
Yeah.
Thank you so much, Dr. Underwood.
Oh, you're very welcome. This is, something that I not only treat, but I'm also a patient. I've had ulcerative colitis since I was a young kid, and that's what inspired me into medicine.
Oh.
So, a lot of these medications that I put patients on are things that I've taken personally, so I'm able to kind of relate to them, what it is that could happen and what to look out for. And once again, this is something that we are still learning and understanding. When we talk about medications are important, surgery is important, but it's our approach outside of that is very, very important as well, which is diet. Okay, diet has a direct influence on inflammatory bowel disease, so understanding what foods to eat and what not is as essential as any medication I could ever give. And then lastly, which more recent research is on the mind and gut connection, in that what's going on here mentally can definitely affect our intestines. And that's for many different processes, but especially so in inflammatory bowel disease, ulcerative colitis, and Crohn's disease. So being able to kind of take my past experience and relate to patients has been a wonderful thing, and a joy to kind of walk down the path of treatment with them.
Oh, wow. On that note, can I ask a couple more questions?
Of course, always.
So how old were you when you were diagnosed with?
Yeah, so I was diagnosed when I was about 16, 17. I was a surfer, I still am, but I was surfing in the ocean. I thought I got sick from a bug in the ocean, and didn't want to tell anyone. I got sicker and sicker and sicker. And eventually saw my primary care doctor, who was wonderful and got me through a bunch of tests, and eventually over to a wonderful gastroenterologist, who then was able to diagnose me. So about the age of 17, I'd say.
Oh, and you had a lot of family support.
Yeah, I think key to any disease, any ailment, is having that structure and the support. And I was fortunate enough to have family that could really help me and take care of me and were understanding. As a kid, you don't like to talk about these things, and even as an adult, we don't like to talk about them with those around us. We are worried that what's going on with us may affect them, or you may be embarrassed, but in the end, with that support, people can be very successful. So I always felt like I had my family, and also I had my doctors. And having a good communication with your primary care doctor and then your specialist is also equally important, and they will support you so that when you are feeling sick, you have someone to call, someone to talk to, and may be able to even take care of it right then and there before it gets out of hand.
Wow. Last one. And from the point that you got diagnosed up until now, what is it like to live with it? You've learned to control it, and you learned?
I think, it's obviously been a long journey, and I think with any illness that is chronic, that is lifelong, understanding that it is lifelong, that it is going to affect you the rest of your life, that you're going to have good days and that you're going to have bad days. But the goal is in having more good days than not. And so becoming educated as much as you can. And I have patients that know so much about their colitis, and I'm so proud of them because they've educated themselves. Never be afraid to ask questions. Never be afraid to do research on your own. That's okay. Bring it to your doctor. Say, hey, I was reading this. Is there any truth to it? Or is this something that we might be able to try? Never be afraid to ask those questions. And that helped me a lot. I ended up growing this interest for medicine and followed this path, which was often very, very difficult. Imagine having flare-ups and being sick when you're the one taking care of patients in the hospital as a resident, or getting a blood transfusion in the emergency room while going and doing consults right after. It was a difficult life. But no matter what it is, just understanding that you're going to have those good days and bad days. Really appreciate those good days. Learn your health and your body and what your body's trying to tell you, such that you can prevent those, the frequency of those bad days. And understanding that by listening to your body, you are going to live a much healthier life than maybe even others that are naturally healthy but just eat whatever they want and do whatever they want. You're going to be more in tune with your body. Appreciate that knowledge. Appreciate that life.
Well, thank you so much for your time, Dr. Underwood.
You're welcome.